Okay, everyone, it is 7 p.m. Central European time, and welcome to the Collective Minds Liver MRI webinar series. This will be webinar number 4, as we have done sessions in the past, an overview in December by Dr. Maarten Thomeer. We did an overview of the MRI protocol and the use of contrast agents with Dr. Thomeer and Dr. Myra Kuijpers. Both of them will present today on the topic of adenoma. And for those of you who missed the past webinars, all of them will be available on Collective Minds. And what you're seeing right now is the Liver MRI webinar series page on Collective Minds. And for those of you who didn't yet receive a user account, reach out to us, sign up yourself. This should have been an option in the registration. When you are logged into Collective Minds with your personal user account, you can access the Liver MRI webinar series group at the groups menu on the top of the page. And by scrolling down, you can access the content from the previous webinars, the recordings, along with the cases. The cases for today, webinar number 4, they are available using this link. That will take you to a page where you have the cases, where you can easily toggle from case 1 by pressing open review mode. And this will load the default display protocol. Close the DICOM viewer and move on to case number 2. And of course, to the left, you have the possibility to toggle through the various series, case number 3, and so on. Of course, Myra and Maarten will share their screens during the case presentations, but we will begin with a lecture. Before beginning the lecture and introducing today's speakers properly, I would also like to give some information for the coming webinar session in May. And for this webinar, it will be quite special. We will ask you to bring your own case. So this is a possibility for you to upload your case to Collective Minds and have your case reviewed by the experts in this series. And so in order to do this, you log on to Collective Minds, and from this page of the Liver MRI webinar series, simply scroll down and press post a new case to this group. So after the webinar today, we invite you all to upload your own liver MRI cases, which you would like to have discussed in the coming webinar series. And our expert group will make a selection of the cases that will be reviewed. The important thing to note here is that please do not reveal the final diagnosis. Please just provide the clinical information necessary, as the final diagnosis will not be known by one of the experts who will be reviewing the cases for the upcoming session. So with that said, Myra, Maarten, welcome and thank you for joining again. How is the weather in Rotterdam?
Well, I didn't see the weather. We were inside all day long preparing the presentation.
Lovely, lovely. And so we will begin this session with the presentation of Dr. Thomeer on benign liver lesions and specifically adenoma, which will be the topic for today. And then Myra and Maarten, you will go through some of these cases using the methodology we've used before. So Myra is reviewing the case under the supervision of Maarten. So with that said, we will begin today's webinar with a brief, around 15-minute presentation on adenoma. So here we go.
Good evening. Today, Myra and I would like to deepen in the diagnostic possibilities, how to diagnose hepatocellular adenoma, non-invasively with MRI, and how to differentiate it with other common liver lesions. But first, let's start with the introductory case. The case is about a young woman using oral contraceptives. She has undergone a sonography of the liver for suspicion of bile stones. And this is what we found. A very heterogeneous liver with multiple nearly isoechogenic lesions. Hepatocellular adenomas were suspected due to the combination of the use of contraceptives and the multiple nearly isoechogenic tumors. We therefore advise for a subsequent MRI with Primorist. This is the T2-weighted fat-saturated MRI of the liver. Directly, you can see the stones in the gallbladder, which was the reason for the primary referral. Apart from this, at least one lesion can be discerned in segment 5, Not sure if there are other lesions in this axial slice. Next, we look at the different contrast phases after primo-mist. We see appearing multiple hypervascular lesions in the same axial slice. This is a closer view of the hepatobiliary phase after 20 minutes. Most of the lesions show iso-intense uptake, suggesting FNHs. However, this was not quite the case. The T1 in-phase sequence of the same axial slice can give you the clue. Typically, look at this lesion and compare it with the intensity of the lesion in segment 4. I will discuss this further at the end. This is how I will do my lecture. First, I will sum up the different clinical features of adenomas. For most of you, this will become knowledge. After this, I will go into the different subtypes. I will finish by giving you tools how to differentiate this benign tumor with the FNH and malignancies, especially metastasis and HCC. Now some general features concerning hepatocellular adenomas. Although it is a very interesting tumor for research, it's quite seldom. It is typically seen in young women using oral contraceptives, but it can also be detected in men, and in these cases, they are premalignant and should always be resected. As it was in our case presentation, they are often found incidentally. Clinically, right diagnosis of this tumor are important because of the internal bleeding, which can be quite extensive, and more seldomly, the degeneration in HCC. Now concerning treatment. In all cases, oral contraceptives should be stopped and eventually replaced by intrauterine device. Diet and lowering alcohol intake is advised since they influence the hormonal status. Currently, we advise follow-up eventually up to menopause. In normal circumstances, they will diminish in diameter of time. Invasive treatment is currently only advised if complications are expected over time. These indications are mainly a large diameter of the tumor and signs of premalignant condition. Pregnancy is a relative contraindication. However, we recently published a multicenter study where we found that monitored pregnancy can be quite safe for adenomas smaller than 5 centimeters. Currently, there are 6 subtypes of adenomas. All 6 subtypes have typical features on immunostaining and molecular diagnostics. First subtype is the LAFBP negative adenoma or steatotic adenoma. Second and most prevalent is the inflammatory adenoma with a subset of beta-catenin positive adenomas. Adenomas can also harbor beta-catenin without being an inflammatory adenoma. That's subtype 4. Then you have the unspecified adenomas without typical pathological features. The last is the sonic hedgehog adenoma. However, it seems that the diagnosis of the subtype with ASS1 is hardly replicable in other centers in Europe. A new pathological marker is currently subject of research. Regarding the main complications, bleeding and malignant transformation, subtyping can be helpful. First, we currently know that steatotic adenomas hardly show complication, and conservative treatment is therefore advised in this subtype. Beta-catenin adenomas, are most particularly with exon 3 mutation, are most feared due to their premalignant presentation. And last, the sonic hedgehog adenomas have a high chance of bleeding. Now that we know the clinical features and the presentation of adenomas, it would be interesting if we could differentiate the different subtypes with high confidence. However, this seems quite a difficult task currently. There are 2 features, however, which are very reliable. These are first, diffuse and homogeneous darkening on the fat suppression and out-of-phase imaging indicating microscopic fat. It's important to remember that the whole lesion has to be black. If only a part of the tumor is darkened, it can be every subtype and even an FNH. Second, the sinusoidal dilatation is a very typical feature of inflammatory adenomas. both in bad gut positive and bad gut negative subtypes. I will now deepen into some cases with intralesional fat. The liver lesion, you can see here, has a central kystic part which is hypointense on T1 and hyperintense on T2. The tumoral part is homogeneously hypointense on the in phase and diffuse and homogeneously hypointense on the outer phase, indicating steatotic adenoma. Furthermore, you can see that the lesion causing pseudo washout in the portovenous phase due to intrinsic fat. So this is a typical steatotic adenoma with an internal kystic part. All solid parts are homogeneously suppressed on a fat suppressed imaging. This is another typical example of a steatotic adenoma becoming black on the outer face, the left side. No biopsy is needed in this case. Simple follow-up can be advised since there is a very low chance of complications. The second typical sign is sinusoidal dilatation. These are vascular venous spaces in the lesion, mostly at the periphery, but also it can be diffuse. The typical features on MRI are increasing enhancement in the portovenous space, higher than the surrounding liver, and hyperintensity on T2 weighted imaging. Sinusoidal dilatation is a typical feature of inflammatory adenoma and never seen in other subtypes or HCC. Here are some examples of hyperintense peripheral bands with central islands. We published this in 2011 as the atoll sign. Here's some typical cases with a peripheral band and central islands. This is our publication in 2011 with a typical atoll in the ocean. Another clear example of this subtype, the peripheral band and central islands, typical for inflammatory adenomas and sinusoidal dilatation. But it can also be more diffuse throughout the tumor, like in this case. After contrast injection, you can see the persistent hyperenhancement in the portovenous space and after 3 to 4 minutes. Very typical for sinusoidal dilatation. This is another atypical inflammatory adenoma. However, in this case, the central isointensity, like in atoll, has changed into black due to the all bleeding with hemosiderin deposition. So the sinusoidal dilatation is in the periphery and the central isointense region has now become dark. So this is an inflammatory adenoma with the all bleeding. In clinical practice, the main task of a radiologist will be to differentiate this tumor with the other tumors. These can be metastases from a known or unknown primary. The most important clue is that metastases are never isointense on T1 in phase. This is because they do not contain hepatocytes like in the surrounding liver. Only if the metastases are very tiny, they can be very difficult to see on the T1 in phase. Other more common features of malignancy can also be used. These are washout and diffusion restriction on the ADC. Furthermore, metastases show never uptake in the hepatobiliary phase. There are some exceptions, like in neuroendocrine metastasis. Here the uptake is due to local stasis instead of a real uptake. Then the most important differentiation of adenomas are the FNHs. Without using Primawis, it's often very difficult to differentiate with. If a lesion is intrinsically hyperintense on T1, it cannot be an FNH in our experience. If the lesion is hypervascular and homogeneously, with the exception of the typical scar, Primawis can be obviated, since the diagnosis of an FNH can be stated with very high confidence. So if you have a homogeneous lesion with a central scar, hypervascular, you can make the diagnosis without using Primawis. In other cases, we always prefer to use an additional Primawis scan. As last, the differentiation with HCC. Currently, HCC are more often seen in non-cirrhotic livers. In these cases, underlying hepatitis and alcohol abuse is not present. These tumors seem to become more and more prevalent, and therefore features of malignancy should always be kept in mind when reviewing a solid liver tumor. These include washout, restriction, growth, larger than 5 centimeter, especially adenomas larger than 5 centimeter, heterogeneous on T2, and nodule and mosaic pattern. As conclusion of this session, I would like to stress again the different hallmarks for subtyping adenomas, which are few but very diagnostic. Secondly, always keep in mind the typical signs for differentiation, including HCC in non-cirrhotic liver. Let's go back to the case from the beginning of the session. There are multiple lesions in the liver, but they all seem to be quite iso-intense to the surrounding liver. So the preference would be FNH, adenoma, or HCC. Now on the dynamic phases after Primovis, they all are hypervascular in the arterial phase. One shows washout or pseudo washout, and all the other lesions shows uptake in the hepatobiliary phase. And in the lesions which are hyperintense in the hepatobiliary phase, they show scar tissue which doesn't show any uptake. So this could conclude all the lesions are FNH except the hypointense lesion, which appear to be an adenoma. However, this is a close view on the hepatobiliary phase. And if you look now at the T1 in-phase image, you see that the lesion in segment 5 is slightly hyperintense to the surrounding, and the other lesion in segment 4 is iso-intense to the surrounding liver. And as I stated before, the intrinsic hyperintensity is not typical for an FNH. Although this lesion and this lesion both show uptake of Primovis in the hepatobiliary phase, this is an atypical lesion because it's hyperintense on the in phase. So it's more prone to be adenoma. And if it is an adenoma, it shows uptake in the hepatobiliary phase. So this is also suspicious for beta-catenin adenoma. This is some measurements we did, and we showed that the lesion is slightly hyperintense to the surrounding liver on the in-phase images. So finally, the right liver was resected because of the suspicious aspect of the lesion in segment 5. On pathology, this seemed to be a beta-catenin adenoma with exon 3 mutation. So these are the most premalignant adenomas. The other lesions were an unspecified adenoma here and different FNHs with central scar. Thanks for your attention. I hope this short overview will help you in the future in your daily practice. We now go to the case supervision part. Thank you.
Thank you so much. So with that introductory lecture, I would like to give the word to today's case session to Maarten and to Myra. However, first we did have a question in the chat. Do you use Primovis at first instead, or first simply gadolinium and hepatobiliary contrast agent as a problem solver?
Yes, that depends on the clinical background. If it's a young woman, I always prefer to use Primovis. In other cases, I do. It depends. If you suspect malignancy, you always do. I prefer to use non-specific contrast agent.
Great, thank you. So with that said, over to you for today's case-based session.
Okay, so I will start by talking about the first case.
Can you see the screen, Frederick?
No, not yet.
Are we doing something wrong?
I'm not sure. Press the share screen button and you will see.
Ah, okay. You didn't say that we have to do that. Screen one.
minute. Is dat een opname? Ja. Okay.
Is this better?
Great, much better. Thank you.
Perfect. So I will talk about the first case, which is a female of 46 years old. She uses oral contraceptives, and other than that, she has no medical history. And she had incidental findings on abdominal CT before, and that's why we performed an MRI with Primovist. So like the last time, if we are going to assess the lesion, we will have a look at the dynamic series, but first we are going to look at the liver itself to see if there is any underlying liver disease. So if we look at the T1 before contrast and administration, you can see no signs of cirrhosis. So there's a normal segment variation, normal contour of the liver. And the other important thing to look at is, I think, the steatosis. And to assess that, we look at the in and out of phase. So this is the in phase. This is the out of phase. So I noticed that there is a signal drop of the liver parenchyma over here, diffuse. Well, and we see some lesions in the liver. I think we will get to them later. And I was wondering if there is maybe, because this is the biggest lesion we're going to talk about, but are there also some fatty areas?
There seems to be some fatty components in the tumor too.
Yeah.
So what we will discuss that later on. But first, I would always ask to first in your report to write down if there's cirrhosis or steatosis, and always start your protocol with this sentence.
Yeah. Okay.
But now you have the dynamic phases.
Yeah. So I'll put up the dynamic phases. We have before contrast arterial 1 and 2, and then we have venous 1 and 2, and then I think it's best to put the T2 weight images here.
Perfect.
So like we discussed on T1, we have some steatosis, and the first lesion we see is the big one over here, which is slightly hyperintense compared to the liver. There are also some smaller lesions visible. And then there are 2 arterial phases, and I was wondering why this one has so many artifacts.
That's a typical artifact due to the use of Primovist. And there's a kind of breeding artifact that happens only in the arterial phase. And other contrast agents doesn't have this this drawback. And the solution we use is to use different arterial phases. So the second is also the arterial phase. By using multiple arterial phases, you're sure that one is okay. That's how we act. You can also use the dilution of the contrast agent, but that's not, we don't use that.
Okay, so that's why we have 2.
Yes, 2 arterial phases, yes.
This is
also the better one, because there you have enhancement of the porta or the porta tracts.
Yes, exactly. So this is okay. And then we see in the arterial phase that the lesion shows arterial enhancement, so it's a hypervascular lesion.
Yes.
And then if we look at the venous phase, the lesion becomes iso-intense compared to the liver. So there's no washout.
Perfect.
And then if we look at T2, I noticed that there is, it's a heterogeneous lesion, and there are some...
Wait, heterogeneous, that's very important. The term is very important, but there's a difference between heterogeneity without or with certain pattern. And is this a typical pattern that you recognize? If not, it's suspicious. If it is a typical visualization of a pattern, then it's probably not malignant.
Yeah, so I think that there is a pattern.
Yes.
Because we can see all those hyperintense areas peripheral, so like a hyperintense band, and then the central is more, the center is more iso-intense to the liver.
And the other lesions, do they have the same appearance?
Yes, I think so. They are also hyperintense on T1. And they were slightly hyperintense compared to liver on T1 as well. And this is, I guess, the atoll sign.
This is clearly the atoll sign, yeah. Once you've seen it, you can easily recognize it. So the hyperintensity is a kind of sinusoidal dilatation. And how would it be visible in the venous phase compared to the surrounding liver?
So this is an MRI with Primovis.
Yes.
So I think with non-specific, non-liver specific contrast agents, you would
expect that
it to be hyper intense compared to liver.
But now we use Primovis, and that's the reason why it's not still hyper intense to the surrounding, because there's already uptake in the venous and the transitional phase of the liver in the liver. So, but if you know this drawback, it's not a diagnostic problem. So your diagnosis is what you find on diagnosis.
I think this is an inflammatory adenoma. And
the other also, probably, yes.
Yeah, I think all the lesions.
What would you advise now to the clinician? What should the surgeon or the clinician ask to you?
Well, I don't think that biopsy is necessary.
You won't do a biopsy?
Or maybe because it's a big lesion.
Because a big lesion, so if you have a lesion larger than 5 centimeters, and then the suspicion of a malignant degeneration is higher. So we always do a biopsy of a lesion larger than 5 centimeters. Or if there are worrisome signs. But here, this is a typical adenoma, there's no washout, no other worrisome signs, but it's too large. So I would advise in this case to do a biopsy. And did you know the result of the biopsy?
I didn't. Did you know?
Yeah, I did. It was it was an inflammatory adenoma without suspicion of any exon mutation. So it was a simple inflammatory adenoma, and the treatment is just stop with oral contraceptives.
Okay.
But then look further in the hepatobiliary phase. We didn't look at the images because that's very important also.
So these are the images after 15 minutes.
Yes.
Oh, yeah, this is interesting because what I noticed after 15 minutes is that all the smaller lesions are hypointense compared to the liver.
Yes, but there are some tiny enhancement regions, typical for inflammatory adenoma.
Yeah. But the bigger lesion is more hyperintense.
More hyper,
compared
indeed,
to these smaller
indeed.
ones. Yeah, is this a worrisome feature?
This is a kind of worrisome feature because if there's an enhancement, and normally the enhancement must be as much as the surrounding liver, which is probably not the case here, I'm not sure. But then that's a reason more to do a biopsy. Because if there is iso-intense lesion, an adenoma which is iso-intense in the hepatobiliary phase, you never know if it is a beta-catenin adenoma. So biopsy would be promoted here.
Okay. And then I noticed this other lesion.
What's that
right
lesion?
Next to the adenoma.
Yes.
Well, it has a different appearance, I think. I don't think it's the same as all the other lesions we saw. But maybe it's best to start with the dynamic sequences again. So on T1 before contrast administration, it's iso-intense compared to the liver, I guess, with a more hypo-intense center.
Yes. And if it's iso-intense, what's the differential? You mean differential?
If it's iso-intense compared to the liver, it can be FNH, adenoma, or HCC.
Yes, totally right.
And then in the arterial phase, it's again a hypervascular lesion, but there are some areas that do not enhance.
Sharp areas of scar, yes.
Yeah. So in the center, but also maybe here.
Yes, yes. So should you worry about that region? How is it in the hepatobiliary phase on the right lower lobe? Can you enlarge it? So this is quite the same image, but here Why is it not enhancing? Why is there no uptake, do you think, in that region?
I think it's also a scar tissue.
Indeed, there's also so scar tissue in an FNH can be quite sharp, but can also be a region and can be quite large. So you can recognize it by late enhancement in the portovenous phase or later on, and by diminished uptake in the hepatobiliary phase. But this is totally normal. So in this case, this is typical FNH.
Yeah, and it's not something to worry about to see these areas
not
in
at
the
all.
periphery.
So there's no indication for resection biopsy. Even if the lesion enlarges over time, there's no reason for resection or follow-up.
Okay.
Okay, that's
interesting. So this was the first case. Then we go to the...
So we did have some questions in the chat meanwhile.
Yes.
So the first question was how to differentiate between atoll sign and targetoid cholangiocarcinoma.
Well, the fact is, if you have a cholangiocarcinoma, maybe mostly the center of the lesion is slightly hyperintense and enhances also in the late phase due to scar tissue. And that's different from stasis as it is in this case. So here are the vessels are filled with contrast in the late phase. So there's more peripheral and the lesion is very homogeneous. Another thing, as I said before, if you have your cholangiocarcinoma, it's never iso-intense to the surrounding. It's always very heterogeneous. So the differential is quite easy to make normally.
Excellent, thank you. There was one question specifically about the biopsy. So what about sample errors or where to biopsy?
That's a very good question. We will discuss this in the next case, in the last case. Yes.
Excellent, thank you.
That's all cases. They are all questions. Okay.
Okay. Then we'll go to the second case. This is a 40-year-old female, also uses oral contraceptives and has no other medical history. And she had the incidental findings on ultrasound of the liver. This is an MRI with multi-Hans. So I already checked for underlying liver disease. Yes. In this patient, there is no cirrhosis or steatosis.
It's always the first thing to analyze if there's cirrhosis or steatosis.
Yes, exactly. But for the webinar, we will focus now on the lesion.
Yes.
So we will to one arterial portovenous. So I will show you the dynamic sequences first.
Put a T2 at the end, maybe.
Oh yeah. T2, this one. Yeah. Okay. So on T1, before contrast administration, we see this big lesion over here, which is slightly iso-intense compared to the liver, but it's kind of heterogeneous, I think. So there's a more hypo-intense area over here and a more hyper-intense focus over here.
Yes.
So that's interesting. And in the arterial phase, we can see some heterogeneous arterial enhancement.
Yes.
So again, a hypervascular lesion. And then in the portovenous phase, the lesion becomes iso-intense, slightly hyper-intense.
So this is not a scan with Primavist. Is this?
No, this is multi-Hans.
This is multi-Hans. So multi-Hans, the dynamic phase is just the same as a non-specific contrast.
Yeah.
So there's no washout here.
No, there's no washout.
So you would say this lesion is not suspicious at first view.
Yeah, based on the
absence of washout. Yes.
Yeah.
Okay.
But if you look at the T2.
Yes.
it looks different from the previous case, because I think this is a heterogeneous lesion.
Also heterogeneous, yes,
Yeah,
again, but
has
not
no
with pattern or without a pattern.
I don't think there's a pattern here.
Okay.
It's no, and there are different areas in
Yes,
this
yes,
lesion.
yes. And if you hear somebody saying different areas, you have compartmentalization, and compartmentalization can be mosaic pattern or nodule and nodule, for instance. And these are two hallmarks for HCC. And do you see nodule and nodule here?
Yeah, I think this area.
This is a different area, yeah.
And
there's also a nodule in the nodule possibly, yes. So this is a very heterogeneous lesion. What would you propose, to do a biopsy?
Yeah, we could perform a biopsy, or maybe if it's very suspicious, you need to do surgery. So
in our institution, if you see a lesion like this, a large lesion, which is quite heterogeneous, we always do a resection without biopsy. We never do a biopsy because of the chance of false negative. I mean, false negative, you can see a beta-catenin adenoma, but you miss the HCC component, for instance. So this lesion was finally resected, and they found a beta-catenin adenoma with a focus inside a nodule in nodule, which happened to be HCC. So that we did right to do the resection instead of the biopsy, I think. Yeah. Yes.
Okay.
Do you see other lesions?
Yeah, there was one other lesion in this case, and I think it's over here.
Yes. Can you enlarge it? Can you enlarge it more?
Yeah. And then
magnify. Yeah. And left. Oh. Again, push and magnify. Yes.
Yeah, it's over here, but it's
a small hypointense lesion. Yes.
Yeah,
on T2.
so over here.
And how is it on T1?
Yeah, so on T1, it's hypointense compared to liver, so it's better visible.
Yes.
On T1.
And then enhancement.
In the arterial phase, it's difficult to see actually.
Even you don't see it anymore.
No.
So it's not truly hypervascular.
No, and then in the portovenous phase.
And later on, yes, it's hypo. So what is that? What does that mean? Very important sign.
It could be washout,
or
it's a fatty lesion.
It's a pseudo washout due to fat.
Yeah.
Okay, so you can have a washout, which is a pseudo washout due to internal fat. So you have to be sure there's no fat in it. How can you be sure if it is a washout or a pseudo washout?
So we have to look at the in and outer phase.
Perfect.
So I will. This is the outer phase. So the lesion is actually difficult to recognize. So probably iso-intense compared to the liver on the in phase.
So if it's iso-intense, remember again, iso-intense on the in phase, and the in phase is a basic sequence, then it can only be FNH, adenoma, or HCC.
Yeah.
But now on the outer phase, how is it looking like?
It has a signal drop, diffuse signal drop in the lesion.
There are two signs. It is diffuse and dishomogeneously signal drop. These are the two characteristics which are very typical for
steatotic adenoma.
So this is typical steatotic adenoma with pseudo washout. Okay. So it has not to be resected or biopsied, but still we did a biopsy, and the reason was because the patient has already an HCC in the large lesion, and there was a nodule in nodule. So we were hesitating if it was the small lesion was not a steatotic HCC. But normally they are heterogeneous on T2, and they are quite different. But we had to be sure, so we did a biopsy, and indeed it happened to be a steatotic adenoma and not a steatotic HCC. Okay.
All right.
Okay, that's
so
it.
then I think we can go to.
We had two questions. The first one was about the background of this patient. So did this patient too have any complaints or lab abnormalities?
Yeah, if I remember well, there were no lab abnormalities.
I think it says over here, no complaints or medical history. No.
Thank you. And the second question was.
Yeah, that's a good question, because now I stress it again. More and more we see HCCs in non-cirrhotic livers, so without any liver functional abnormalities. We see it once in a month. We have a new case in our tertiary center. So the adagium that you have to have a chronic liver disease is not true anymore, I think, to have an HCC.
We have the second question saying, please explain washout due to fat. And if I recall correctly, it was a pseudo washout, what you call it.
Yes, maybe Myra can explain it. It's very important to make a differentiation between washout and pseudo washout. You really need to understand it.
Okay, so I think I need to put the dynamic phases again to show this.
Yes, maybe you can show the difference between the venous and the before contrast.
Yeah, that's best maybe. So we have T1 before and then
The venous.
orthovenous
Yeah.
2. So yeah,
well, in fact, it's quite easy. So the lesion is already hypointense before contrast. And washout means that it becomes darker than the surrounding liver. But this is true for lesions which are iso to slightly hypointense before contrast. So the lesion is already hypointense. So it's not feasible to get an intensity which is higher or iso-intense to the liver in the venous phase, because the lesion is already hypointense. And you can, and if there's maybe there's also a pseudo plus a real washout, then you can do, to know that, you can do a subtraction. You do a subtraction of the venous phase from the phase before contrast. And if then it's darker than the surrounding liver, then it's also a true washout. But I don't think I think if you do a subtraction here, you will not see any washout. You will see that the liver will be the same intensity as the lesion when you do subtraction. So there is no washout. Okay, I hope it's clear now.
We had one final question. Can diffusion weighted imaging distinguish between steatotic HCC and adenoma?
Well, I think the diffusion characteristics of an HCC is quite typical. They show diffusion restriction. So I didn't show it here, but if there's real restriction, like maybe in this case there is. Let me show me the diffusion. It was a beta-catenin adenoma. And we published this case also. And inside there was a nodule in nodule, and there was a lot of restriction in the lesion. You can see here, there's a black region. And that was probably the part there where there was malignant degeneration. So yes. I'm not sure it can help in all the time, but in this case, I think it was suggestive that there was a nodule in nodule.
Yeah, the lesion segment 6 doesn't show
restriction. No. That's also, yeah, adenoma doesn't show any restriction. Also the steatotic adenoma. Is it clear?
Super, thank you.
Okay.
Can we go to the last case? Still one to go?
Please go ahead.
Okay.
So, this case.
That's a special one.
Yeah, so the third case is a 25-year-old female, also uses oral contraceptives, and this was also a sonographic finding. So again, no cirrhosis or steatosis.
Okay.
So I will get to the lesion first. So this is an autophase. Okay, so the dynamic series. I will put up first.
Yes.
Corona maybe, and then T2.
And a T2, yes.
Oh yeah, okay, there's two. Yeah. Okay, so first, T1 weighted images before contrast enhancement. We see this big lesion over here, which is iso-intense compared to the liver.
Yes.
So again, we have to think about FNH, adenoma, or HCC.
Yes. It cannot be a cholangiocarcinoma, for instance.
No.
But there's more. There's something more happening. Look at the T1 before contrast. There are some regions which are hyper intense.
Yeah.
So if there is hyper intensity in the lesion, and it's a real hyper intensity, look at the in phase T1 maybe. Can you look at the T1 in phase? Because that's the basic sequence. There you know sure about the different intensities.
Here.
And can you see some hyperintense regions? There you see some hyperintense regions.
Yeah, I can see them.
So if you see on the in phase hyperintense regions in the tumor, what can it not be, Myra?
FNH.
Perfect. In my experience, an FNH never contain hyperintense regions on the in phase. That's important.
Yeah.
Okay. Now go to the dynamic.
Yeah, so I'll put them up again because over here, this one, third, and then I will take the T2 images. Okay. So iso-intense compared to liver with some hyper-intense areas. In the arterial phase, we can see heterogeneous arterial enhancement.
Yes.
In the venous phase, it becomes iso-intense, slightly hyper-intense compared to the liver.
Still hyper-intense. Yes.
It's still heterogeneous. There are some more hypo-intense areas.
Can you show me the hypo-intense region more closely? There.
Over here, yeah.
You see there's a part of the tumor which is different from the rest.
Yeah.
Okay. Does this region or the rest of the tumor show restriction on diffusion?
So this is ADC. The high B value, I think.
Yes.
Yeah.
So it's hyper intense on the high B value.
Especially this area, I think.
It's not quite. It's not different, isn't it? No, I don't see a really different.
No.
And there's no real restriction, so I'm not that worried.
No. Okay, and if I wanted to look at the T2 weighted images, and I noticed that there are two different sequences.
Yes.
And I was wondering, where do we use this T2 weighted sequence for?
Well, long ago we used always two echotimes for the T2, and that is the echotime with 350. That's a long echotime, and the other is. Can I go back? And with 70 to 90 milliseconds. And if you have a longer echotime, there's a dephasing of for all tissues except the water. So in the longer echotime with 350, you will see mostly only water signal and fat. Okay.
Yeah.
So if you look here, the lesion again is hyper intense on T2, and in the longer echotime, I don't know if you see it, but there is a nodule in nodule here, and there's also a dark region here, which is quite heterogeneous. Huh?
Yeah.
So this is probably a region where there's less water, and here also. Okay. Because on the longer echotime, you will mainly see water. Okay, so what would be your advice to the clinician?
I think we need to perform a biopsy.
What's the reason for the biopsy? Are there were some signs?
Yeah, there's a nodule.
There's a nodule, and always when you see a nodular appearance, you better do a biopsy to be sure there's no HCC or beta-catenin adenoma. So that's true. Yeah. Are there other signs of malignancy?
Well, it's a big lesion, so probably the
yes,
size
that's also a reason. We do always mostly a biopsy when it's larger than 5 centimeters. Yes. Yeah. Except for steatotic adenomas. And then the lesion is also heterogeneous on T2. You saw it in the lower compartment. There were some hypointensities on the. Yeah. So some parts which were different. Yeah. So what we suggested is, because the lesion is quite heterogeneous. And because the lesion was quite easy to resect, it was below segment 4. We proposed a resection, and that's what they did. So the results of the resection was an inflammatory adenoma. That's what we would expect, of course, because there is enhancement in the late phase, and there's hyperintensity on T2, all typical aspects of an inflammatory adenoma with sinusoidal dilatation. But we did also molecular imaging, a molecular diagnostic. So we did next generation sequencing for exon mutation in the largest part of the tumor. There we found no exon mutation. So if you see an exon mutation, it can be exon 3, it can be exon 7 or 8, then it's a beta-catenin adenoma, which are pre-malignant. So there was no reason for malignancy or pre-malignancy in this case. But for the first time, we tried also to look more specifically to the region here below. We did also a molecular diagnostic in this part, and surprisingly, we found an exon 3 mutation in this part of adenoma. And this was for us, this was 2 or 3 weeks ago. This was very surprisingly for us. Normally, we don't do a biopsy in a specific part of the tumor, but maybe in the future, it could be advised to biopsy in the region which is the most suspicious, I presume. But I have no other arguments to do that. So this is only the first case we see with this problem. It's known from literature that from a publication in France, that more than 90% of the adenomas are homogeneous in subtype. So there are some seldom cases which can be heterogeneous, like in this case. So I don't know if this could be helpful to guide the biopsy. Okay. Yeah.
So any other thing? No, I think this was our 3rd case. So I don't think if.
So to give also an answer to the question before, so I think we will in the future guide our biopsy more in the regions which are suspicious, yes. And that will not be a region of necrosis or hematoma or kystic parts, but really a region which is heterogeneous without a typical pattern.
We had a final question regarding the biopsy. So how do you biopsy the right part? Is it MR guided or is it ultrasound?
We do it ultrasound guided, yes. Not MR guided. It takes too much time from the MR suite.
And do you use fused ultrasound with MRI?
Did you? Myra does the biopsies.
Yeah, I performed a biopsy 1 week ago with a colleague, also of an adenoma, and we did also not biopsy a particular part of the lesion. So that's an interesting finding that Maarten told us about. But I also used the ultrasound, and
combination of ultrasound and CT maybe sometimes.
Yeah, sometimes if a lesion is hard to visualize, we perform it with CT and ultrasound together, but never with MRI.
But do you use fuse imaging? Do you? I don't think so.
We don't use it in the clinical setting.
We did some years ago, but I don't think we have clinical practice on that anymore.
No.
Okay.
but should be interesting if we have to biopsy certain parts of lesions.
There was a question, do you have a suggestion for a paper to read on types and guidelines for management?
Yes, I published some years ago in 2016 advances in therapy on adenomas, but nowadays there's also a new paper of Nolt. I will write it down in the Nolt. Okay, I think it's a paper in gastroenterology, but I'm not sure. This gives it a very nice overview.
Okay.
And also there's a nice review from Villegrain in which in the Journal of Hepatology about benign liver tumors and how to act.
Excellent. I wrote the names in the chat here for all of you.
Okay, thank you.
And I mean, to make some final remarks, so there will be an interactive component between now and the next webinar. So all of you have the possibility to, for each case that has been posted for this webinar and for previous webinars, you can review the cases yourself, obviously, but you can also press the reply button to ask any questions. And this can be done as many times as you want. It's for free, so please take the chance. For the next webinar, as we mentioned, there will be a case-based bring your own case session. So this will be very exciting, we think. And please take your time to pick out your liver MRI case and upload it to the liver MRI group. Do not reveal the diagnosis. If you upload the case, we will contact you for further instructions. And when we close the webinar tonight, we also kindly ask everyone to fill in the course evaluation. This will be sent to you on an email directly after the webinar. This is very important for us. And if you have any suggestions how we can improve even further, we're very, very grateful for that. I'd like to thank you, Myra, Maarten, again. This was
a
very, very nice session. It's great to see these interactions between the two of you. You seem to be doing a great job, Myra. So congratulations. And last but definitely not least, we'd like to thank our sponsor for this event, Bioradiology Nordics. Thank you so much for your support to make this happen. And we hope you all enjoyed. So with those remarks, we'd like to thank everyone and have a great night and see you next time and hopefully even before that. So please post your cases, post your questions, and we'll see you there.
Thank you,
Thanks so much,
Frederick.
everyone. Thanks. Have a good night, everyone.
Have the same.
Thanks.
Bye.